All right. Well, thank you all for being here, and appreciate everybody's accommodation with the times and all of that. So I'm Ian Neal. I'm a geriatrician at UC San Diego, and I'm a part of this group, the San Diego Alzheimer's Project. And so when we were thinking about kind of things that we could talk about with behavioral health, there's a lot of different potential options that we could discuss. But one thing as a geriatrician that's always near and dear to my heart is talking more about kind of what can we do to take a look at a patient who's having behavioral issues and see, is there anything we could be doing non-pharmacologically or from a physiologic standpoint to try to help with behaviors before the knee-jerk response of patient's agitated, let's reach for the Ativan or the Haldol. And one thing that I think is always important to note is kind of, and whenever somebody comes into me for behavioral agitation, the first thing that I do is I say, what are their meds? What are they on? What have they started recently? And also, is there anything that could be going on that could be causing a delirium, an acute change in cognition, that's explaining these symptoms? And so that's often a good first place to start. And so one that I want to focus on today with the talk. So we have this refresher here on the 4 M's of age-friendly care. This is really what the American Geriatric Society is really very excited about. The 4 M's are a framework to help look at kind of the different things that a geriatrician looks at when they're thinking about a patient. Many geriatricians don't actually like the 4 M's because they feel like it dumbs down our field too much. But it's been a really great selling point for geriatrics, and it's helped us really be able to make health systems and government entities understand why geriatrics matters and what is it that a geriatrician does that's different from a regular internist. And really it's kind of focusing on these kind of big overarching categories. What matters, which actually starts with a W, not an M. Medications, mobility, and mentation or the mind. And so today is going to be kind of highlighting 2 of those big M's of medication and mentation. So in particular, when we're seeing a patient who's coming in for agitation, the first question always should be, what's going on that's changed that could be causing this agitation? Could we be missing something such as a delirium? And delirium is something that we define as distinct and separate from a dementia disorder. That's an acute change in cognition. In order to meet criteria, we have the diagnostic criteria here. First is that you have to have a disturbance in attention and awareness as well as in another domain of cognition. This is why all the delirium scales, things like the CAM-ICU or the Delirium Observation Screening Scale, the biggest thing that they focus on is there a change in attention? And so if we're seeing a predominant attention issue, then delirium may be a potential. Typically, delirium develops quickly. It's not something that kind of smolders and comes up on you over a matter of years. It's something that should be, they were fine, and the next day they're throwing everything at the wall. It also traditionally fluctuates in severity throughout the day. This is why we call what we say about kind of the waxing and waning nature of mentation with delirium is that you have good times, you have bad times, and it kind of ebbs and flows as the day goes along. Typically, it gets especially worse early in the mornings and late at night. Also, that disturbance can't be better explained by a pre-existing neurocognitive disorder. And most importantly, there should be evidence on history, exam, or labs that the disturbance is due to something. Delirium is always due to something physical happening to you. We care about delirium because it's an independent predictor of morbidity and mortality. Studies, as you can see, there's a wide range here of morbidity, mortality factors, but there is a 22 to 76% chance of death during a hospitalization from delirium based on the study you look at. On average, it's probably more around the factor of about a 30% one-year mortality after you've developed a delirium episode if we kind of pool all the studies together. But that's a pretty big risk. It's about the same mortality risk as a sepsis episode. And so we have to take these things seriously. And the other thing that we worry about with delirium is that it's really intricately linked to dementia. If you have dementia, you're more likely to get delirious. And if you're delirious, you're more likely to have dementia. So, if I have a patient and I have them come back to me and they're like, Doc, I was just in the hospital and, they told me that I was in restraints and spitting at everybody and just really out of it, then I'm going to be wanting to do a cognitive evaluation on that patient once they're back to their baseline to see, is there any dementia here that's gone unrecognized that was unmasked by this delirium episode? The worst mnemonic I ever was taught in medical school was this, which is to try to teach us how to remember all the different causes of delirium. They said, it's simple, just take the word delirium and then you've got the different causes from all the letters. But when you look here, you see that basically everything that's in Harrison's internal medicine potentially fits into this mnemonic, because in reality, anything can cause delirium. You could get delirious from stubbing your toe and your toe hurting if you have advanced enough dementia. It's unlikely, but it can happen. The most common things that we see that cause delirium, number one is up in the D, the drugs section. They also mix that in the M of medications, both pharmacologic and non-pharmacologic drugs and medications can be a major factor that causes delirium. Infections, of course, is big on the list, but there's also a lot of stuff that's on the list that we don't normally think about as a medical cause of delirium. Unfamiliar environments, restraints, restricted mobility, impaired sensory input, poor vision or poor hearing. Long hospital stay. Our environment can be a major factor that increases the risk of delirium. They say that at least 50% of patients in the ICU will develop an ICU-induced delirium just from the nature of being in the ICU, having their sleep disrupted every hour for vital sign checks, having all these advanced lines and tubes put them in, which restrict their movement because, it's hard to get up and move around if you have a vent in place or if you've been tied down by 3 central lines. That alone can be a cause of delirium. Additionally, just the unfamiliar environment itself, just being in the hospital and being in this confusing place can be a delirium factor. One of the big things we often will say of patients who are delirious in the hospital is step one is move them to a bed next to a window. It doesn't seem like that's something that's a major impact, but it is. And you can actually reduce delirium severity by having access to a window, because what that does is it gives you the ability to see outside, ground yourself in reality, know that, hey, yes, I am still here on Earth, which even that can be confusing and difficult to discern in a delirious episode. So really anything can cause delirium. And so when we're looking at a patient who is delirious or who's having behavioral agitation we're concerned may be delirium, we want to really look at that whole patient and see what is it that could be going on here that could potentially be contributing to their agitation and address anything that we can from a non-pharmacologic standpoint to try to treat that. And if we see that behavior still persists despite that to the point that it's causing them or others to be at imminent risk of harm, that's really when we start to reach for medications for behavior. But we really want to try to address all of this first. And oftentimes through addressing all of this, we can achieve good outcomes. And so, as I mentioned earlier, kind of my biggest thing when I'm seeing somebody who's delirious is to ask, what are their meds? And it's the first thing I always turn to. And the reason is that medications are a major cause of delirium, both giving too many meds, giving not enough meds, or the way meds interact in our system all can kind of be factors that impact our risk for behavioral agitation. In particular, this thing called polypharmacy is widely recognized as a major issue in seniors and increased risk of delirium independently of other factors. We define polypharmacy as being a subcategory of this bigger issue called suboptimal prescribing. And suboptimal prescribing can be broken down into these 4 components. Polypharmacy, which is just too many meds. underutilizing meds, not giving pain meds when there's pain, for instance, inappropriate prescribing of giving meds for pain, but using the inappropriate ones for a senior. Putting a 93-year-old on a high-dose naproxen for their arthritis and causing a stomach ulcer that's going to lead to PO intake avoidance and malnutrition and agitation from that, for instance. Or using the incorrect dose. I always say the starting dose of pretty much any med in an older adult is half the baseline starting dose. Kind of less is always more in patients to try to make sure that we're titrating up slowly and minimizing side effect burden. And we care about all this because the adverse drug event, which is a negative outcome as a result of a medication, has been really found to be almost similar to delirium, a very high risk of death. It's estimated that 5 to 30% of all geriatric acute care hospitalizations are due to an adverse drug event. And 50% of the hospitalizations of those over the age of 80 are due to one of these. The most common offenders are warfarin, antiplatelet therapy, insulin, and oral hypoglycemic agents. And we know as well that there's a higher incidence of adverse drug reactions in minority groups, particularly among Black and Hispanic minority populations. And so there is a lot of health inequity related to these medications. And so it's something that we really need to focus on and what we in geriatrics focus a lot on. So how do we even start with thinking about medications and what to give, what not to give? That's kind of the crux of this lecture. The thing that always happens when I start to talk to a patient about, hey, we should maybe start reconsidering some of these meds you're on, is I get this comment. I've been on this for 20 years and have never had a problem, so why should I change it now? And I've had even experienced seasoned physicians who have told me the same thing. They've been on this forever. It's never caused them problems now, so we don't need to worry about it. You may. And the reason is that your kidney and your liver are quite different when you are 80 than when you're 40. We have lots of things that change in our body and change with our organs as we age that could make it that the way that we metabolize drugs, the way that drugs interact in our system, differs than when we're younger. So something that may have been helping us for the past 20 years may start causing side effects when nothing else has changed because of the fact that our organs have aged. And so, these are one of the kind of core tenets that we try to teach all of our geriatric medicine and psychiatry trainees is how to think about the way these organs change when we're prescribing. In terms of big ones that we worry about with respect to medications, these are just a few of them. One is that we know that as we age, our nerve firing speed slows. We've actually seen this when we do nerve conduction velocities on people, is that as a normal part of aging, the speed in which a nerve fires slows down. That's why as we age, we have a higher risk of loss of proprioception in the feet because those are the smallest and most distal fibers, and so it takes longer for nerve signaling to reach there, which can lead to more imbalance issues. It's also why reaction times are slower in seniors and why we worry more about seniors driving. But what that also means is that drugs that slow down neuronal function, say gabapentin and things like that, may have a more robust response as we get older. We also know that as we age, as a normal part of aging, we lose body mass due to loss of largely muscle tissue. Sarcopenia or loss of muscle tissue is a normal part of aging. And so that can affect drugs that are metabolized through either storage in fat versus muscle. We may wind up having more free drug available if a drug is normally stored in muscle and there's just not enough muscle around anymore. We see that there's skin changes as well. The thickness and elasticity of our skin changes, which can have more variable affection on drugs that are absorbed topically. So especially if somebody's like getting a med from a compounding pharmacy, for instance, we may take up more of that than would normally be thought. I haven't been seeing a lot lately, but there used to be this popular cocktail of giving this combination of Ativan and Haldol and Benadryl in a compounded cream that you could just like rub onto the agitated patient and calm them down, and families liked it because they didn't have to give a pill. But what we were seeing with that is they were already pretty high doses because the thought is, well, they're going to absorb slowly over time. But in patients with really reduced skin thickness, we're going to see a lot more of that absorbed quickly, and it wound up snowing a lot of our patients and winding them up in the ERs. Bone mass also gets lost as we age, increases the risk of things like falls and fractures and stuff like that. Our heart gradually loses pacemaker cells as we age, and it also thickens as we age, which makes it that there's a higher risk of having nodal issues if we're on medications like beta blockers, or if we're on donepezil for dementia. That may wind up having an increased risk of causing heart block in the older adult because of this kind of nodal dysfunction that our heart gradually develops just as a normal part of aging. Our lung function declines as surface area is lost. That can affect absorption of inhaled medications. Gastric emptying slows after fatty meals, increases the risk of heartburn, but also that reduces the risk of transit time of medications. If we have to take them with food, they may stay in our stomach longer. Especially problematic with those NSAIDs like ibuprofen that'll then sit in our stomach longer and increase the risk of stomach erosions. Not to mention, another thing that happens is that our stomach actually has hypertrophy of the crypt cells, which increases acid production. So already we're at higher risk of stomach ulcers as we age because the acid production in our stomach actually increases as we age. Add on top of that something that's going to increase the risk of that, like an NSAID, and we're just asking for trouble. Our kidney size and weight reduces. It's estimated that we lose about 1 to 3 points of GFR every year of life after about age 30. So sorry, it's all downhill from here with your kidneys. But what that means is that we have to take that into account as we're renally dosing drugs. But because our muscle mass reduces, creatinine comes from muscles. So when we're measuring kidney function through creatinine, it becomes much less predictable what our creatinine level is and what our actual kidney filtration is. And so it's recommended these days that if we're really worried about renal dosing of a medication, to not check GFR through creatinine, but instead use a urine cystatin C, which has similar creatinine clearance calculation to, similar renal clearance calculation to creatinine, but is muscle independent, so is not going to go down and falsely affect numbers as we lose muscle mass. We also see that absorption of certain vitamins decrease due to these changes that occur in the stomach and the intestinal lining. Our liver decreases and blood flow through it decreases, and which can affect liver clearance of medications. And also there may be some age-related changes in some of the cytochrome systems within our liver. This is a little bit more debatable and one that's being kind of actively researched, but there's some evidence that we see, in particular the CYP2C19 system can have some changes where we get less of that around, and so drugs that are cleared through CYP2C19, like all of the antidepressants, may wind up lingering in our system for longer as we get older, and hence why we have lower dose recommendations on certain antidepressant medications. With escitalopram, for instance, like 20 milligrams is the maximum recommended for the older adult instead of 40 for the average adults, and part of it is to account for these CYP changes. So if we aren't thinking about all these and about a million other organ changes that occur as we age, then we may wind up doing more harm than good to our patients with medications. So to try to help with this thing called the Beers List was created, looking at potentially inappropriate medications for seniors. And so the American Geriatric Society took over the Beers List after the clinician that created it finally retired. So they've been managing it since then. Every about 3 years, they update the Beers List with new meds. The problem with that is that the more we've done research on it, the more we've realized there's not a lot of safe meds for older adults. And so actually assessing the Beers List is difficult. This is the Beers pocket card from back in 2016. They've stopped even making these pocket cards these days. But even then, we were looking at 8 pages in about 8-point font to try to list all of the potentially inappropriate meds. So the issue with the Beers list is when you're like seeing a patient in front of you and you got 20 minutes for the visit, how do you access this properly to be able to truly make sense of it and see what do I need to worry about here? And so one table that I like a little bit better is this guy, which also is difficult to read, and I don't expect you to read it here. But this is a table that I find myself referencing pretty much every day of clinical practice. It's something called the Anticholinergic Burden Index. And really what we care about with this is that when we're looking at medications in the context of dementia and potentially the context of delirium and looking to see what medications is a patient on that maybe we could get rid of that could potentially be cognitively detrimental, the lowest hanging fruit is to get rid of any medications that have what are called anticholinergic action. Because the hippocampus, which is the thing that degenerates in Alzheimer's disease, operates through acetylcholine. So anything that blocks acetylcholine potentially can make function up there worse. And so this is why you'll see geriatricians or neurologists bristle anytime you say the word Benadryl about a geriatric patient, is that Benadryl is kind of the classic anticholinergic med. It works great at making us go to sleep because it's suppressing action of the central nervous system through blocking acetylcholine, but when we're hanging on to our last threads of acetylcholine up there in dementia, it may be too much for our brain to handle, and a single dose of Benadryl can actually induce a frank hospital delirium. And so, obviously trying to avoid that if we can, great. And so that's why we're always telling patients, don't take Benadryl, but also make sure you're looking at the over-the-counter meds because I'll ask patients, do you take any Benadryl? And they're like, no, but I do have some trouble sleeping. So, I take Tylenol PM, and then, I've been told I could take Advil with Tylenol. So then I take Advil PM on top of that. And it's like, you do know that the PM in that is Benadryl. Or they're like, no, it doesn't say Benadryl, it says doxylamine, which is actually worse than Benadryl. So I tell them anything with PM in the name, just don't take. But the thing that we realized is that there's a lot more meds that have anticholinergic action than just Benadryl. And there's a lot that we don't typically think of from the way that these drugs interact in our system that should have anticholinergic action, but they actually do. And so this pharmacist was doing some research in his lab one day, and he decided to do just some in vitro titrations of looking at different drugs and seeing how much they bound to the acetylcholine channel and blocked it compared to atropine, with atropine being kind of the gold standard. And so then what he did is he took all those drugs and he put them all in a table, and he gave it a score of either 1, 2, or 3, with 3 being the most anticholinergic, 1 being the least. It's roughly about 20 to 40%, about 40 to 70-ish%, and then about 80 to 100% in the score of 3. And what he found with this is that, there's some things that we obviously know are anticholinergic that make the list. We got Benadryl, or we got doxylamine, or hydroxyzine. Kind of all those meds that we typically think of as anticholinergic, of course, are, and they're up here in the score of 3 category. But there's some that started to make the list that we didn't really think of that would be anticholinergic. For instance, one that we commonly run into is oxybutynin, which is a urinary incontinence medication that can be given for urge incontinence. Oxybutynin operates through blocking muscarine in the bladder that then causes the bladder to relax. But anything that blocks the muscarine receptor is also going to have anticholinergic action. It's kind of comparable in terms of the way that they bind, and so you're going to see significant anticholinergic action from any antimuscarinic agent. And so when we actually compared anticholinergic action of oxybutynin, we found that it was basically the same as taking a dose of Benadryl. So then people went to the drawing board and they came up with other medications that could potentially have less anticholinergic action from a urinary incontinence standpoint. And thus one was born called trospium. And if you talk to a trospium rep, which I never recommend talking to pharma reps, but if you do, they'll tell you trospium's this giant chemical agent that's really hard to get across the blood-brain barrier because of all these hydrophobic elements on it. And so as opposed to oxybutynin, trospium shouldn't cross the blood-brain barrier, so shouldn't have anticholinergic action. But when we actually look at it, we see trospium's here in drug of ACB score of 3, the same as oxybutynin. And so technically it does have the same anticholinergic action. It's just so big that it's probably not going to have as much central action, except in dementia patients. Because one thing that happens as dementia develops is that we see that the blood-brain barrier starts to break down. Those amyloid plaques that you develop in the neurons, those actually deposit in the blood vessels as well. And so what that does as those develop is that it makes it that the blood-brain barrier becomes more permeable. This is why there's a higher risk of leakage of blood into the brain, these kind of cerebral amyloid angiopathy things, these little microhemorrhages. But it also makes it that drugs that don't normally cross the blood-brain barrier may. And so we actually see that in dementia patients, the delirium rate on oxybutynin compared to trospium is pretty much the same. And there hasn't yet been a urinary incontinence med that's in the antimuscarinic class that actually has a lower delirium risk. But those are all the score of 3s. The thing that's kind of more interesting is in this kind of lower category. Score of 2, you're probably not going to be giving much of those meds out. You know, that's stuff like belladonna, amantadine, some antiemetics, some muscle relaxants like Flexeril. Kind of more niche drugs fall into the score of 2. But the score of 1, there's actually a lot of drugs on here that you tell somebody this drug's anticholinergic and they're like, no, it isn't. You know, for instance, if we look down this list, we have atenolol, we have captopril, we have chlorthalidone, digoxin, we have metoprolol, and we have warfarin. So say you got AFib, and you got heart failure. You're already going to be on at least 5 drugs that have mild anticholinergic action. Even Lasix is on here. So does that mean we shouldn't be giving Lasix to heart failure folks if they have dementia because it's anticholinergic? No. You know, these are all in the score of 1, so their anticholinergic action is relatively small, but the result is additive. So say you got that AFib and heart failure patients, and they're already on the metoprolol and the warfarin and the furosemide and the beta blocker and the ACE inhibitor. They're already going to have at least a score of 5 on their anticholinergic burden score. So when they develop urinary incontinence from that Lasix, we're going to be a lot more unlikely to give an ACB score of 3 drug like oxybutynin to treat their urinary incontinence. A, because it's not going to work because it doesn't help with incontinence from Lasix. But B, that may be the straw that broke the camel's back of just too much anticholinergic action. So usually I look at the score of 1 not as let's get off of these, but it's if these are necessary, then we need to be extremely avoidant of adding anything else that could potentially be anticholinergic to try to avoid inducing a delirium in our patients. And this went into that a little bit more. Some other things that are kind of good highlights on the Beers list to think about from a cognitive standpoint by class is that we got the cardiac drugs, and there's a lot of potentially unsafe cardiac drugs to be giving out to the older adult. You know, we got some that are anticholinergic like Lasix and Coumadin, but we also find that certain drugs are just a lot more toxic as we age. So, you know, the antiarrhythmics, for instance, all carry lots of different toxicities. You know, just look at the side effect label of amiodarone sometime, and basically every organ system in your body gets poisoned by that thing. And so we find that trying to stick to antiarrhythmic-based regimens in the dementia patient or the patient with frailty oftentimes has higher risk of adverse outcomes because of all these side effects, and it's often better in those patients to stick with more of a typical rate control based regimen instead. Antihypertensives also can get us into big trouble. Blood pressure control typically should loosen as we age. You know, we've got the Joint National Commission guideline on blood pressure that they came out with a few years back, where they said that, you know, if you're old and frail, then probably your average blood pressure target should be less than 150 over 90. As long as you're less than that, You're good enough that you're not going to develop any macrovascular complications like heart attack or stroke. Maybe 10 years from now, you'll get some microvascular eye disease and kidney disease, but you're probably looking at a life expectancy of less than that. So it's not going to be a fate that comes to fruition for you. But in the meanwhile, a single low blood pressure could kill you. Could increase falls, fractures, delirium, etc. So loosening up blood pressure control often can be significantly helpful to our patients with frailty. And in particular, trying to avoid the alpha blockers, especially clonidine, are kind of a big go-to in geriatrics, because we see that those are the ones that have the highest risk of orthostasis of all the blood pressure meds, and tend to get patients into the most trouble. Some other highlights in terms of some psychiatric meds, things to think about. There is no safe sleep med. Everybody always wants the answer of, well, what med should I give to my patient with dementia who's having trouble sleeping? And the answer is, there's nothing safe, so try something if you need to, but know that it's going to happen at a cost. But in particular, the hypnotics, the Z drugs like zolpidem, we try to avoid in the older adult if at all possible. Especially in the dementia patient because of the risk of delirium associated with them. Typically, my regimen is, for the dementia patient especially, is keep them active during the day so that they're tired at night and more likely to sleep. Try some melatonin at night if you need to for sleep. And try some non-pharmacologic calming things, like Headspace or the Calm app or something like that to try to help with readiness for sleep. And often through practicing those sleep hygiene methods, we can get better effect than giving a medication specifically for sleep. And if you need something more than that, then often relying on a specialist like a geriatric psychiatrist to help you can prevent you from running into trouble there. Antidepressants I have on here as well is just something to think about. I mentioned this briefly with the liver changes of, the way our liver metabolizes antidepressants changes as we age. And so the max dose of a lot of them tends to be lower due to the risk of serotonin syndrome with higher doses. But there are two in particular that are counted as the senior non-friendly antidepressants, and that's Prozac and its cousin Paxil. Those are kind of the least well-tolerated antidepressants in the older adult. Prozac, what we find is that it has a lot more drug-drug interactions, so especially if you've already got polypharmacy and you have to be on Prozac, its metabolism is going to become a lot more variable by all the different meds that you're on, so you may not get the right effect from it, or you may wind up getting too good of effect and develop serotonin syndromes. And then Paxil is highly anticholinergic, and so we can see deliriums associated with Paxil prescription. And then we also see that there's a really high risk of hyponatremia in the older adults on Paxil. So for many reasons, we try to avoid that one. The dementia meds also can wind you running up into trouble in terms of delirium. And so, where I work primarily in the hospital at a place called Senior Behavioral Health, I find myself pretty much always just stopping donepezil and memantine if they're on these. And the reason for it is that both are associated with increased risk of behavioral issues. And so if you're having behavioral issues, you can't exclude these as potential causes. But when we look at the benefit of them, the benefit is small. Donepezil, when we look at its benefit, it's been shown on the MMSE to improve your score by 1 to 3 points based on the study you look at. And that's the only benefit it's ever been shown to have consistently in the literature. There haven't been any functional improvements associated with it. Rates of hospitalizations don't change on it. And even physician or the caregiver well-being surveys just ask the caregiver kind of like, how stressed are you in taking care of the patients? Do they seem a little bit better to you? Even those haven't objectively changed in the studies. But donepezil has a lot of side effects associated with it. 23% of people on donepezil will develop some type of GI side effect. I always say, look at the patient you have with dementia who's on donepezil and see if they're on a PPI. Question is, do they need that PPI, or could we get rid of that stomach side effect by getting rid of the donepezil? You don't know. You have to try it. But one could think, yeah, your stomach's a little upset, but now you're at least having less symptoms from your dementia, right? Well, if you've got, say, moderate to severe Alzheimer's disease, you're also developing significant issue with aphasia. You're having more trouble communicating your needs. So, say your stomach hurts, say you're in a memory care facility, and if your stomach hurts, you're not going to want to eat. So now you're being labeled by the memory care facility as PO refusal. So they're going to protocol you to have a staff member at bedside to help feed you. But if you don't want to eat, and here comes the airplane and they're trying to feed you, you're just going to swat that spoon away. You're not going to be able to say, my stomach hurts, I don't want to eat. You're just going to lash out. Now you're labeled as behaviorally agitated, and you're getting a psychiatrist writing you olanzapine or something like that. Maybe we could eliminate that by getting rid of the donepezil. Similarly, we do see that there's an increased risk of mood disturbance, depression, and anxiety with donepezil use, and that tends to occur later in disease. With memantine, the pharma reps always say that the good thing about memantine is it has less side effects than donepezil, even if its benefit may be less. It's never been shown to have a clinical benefit for patients in the studies. It's always been found to have statistically significant benefit in cognitive test score improvements, but that's it. But all of its side effects are neuropsychiatric. We can see increased agitation, increased hallucinations, vivid dreams, sleepwalking, kind of hypnagogic effects similar to like what you would get if you take ketamine, because it operates on a similar channel to ketamine. Not quite the same way, but you get a similar side effect profile. And so anytime I see behavioral issues developing, I'm quick to get rid of memantine if they're on it, because I can't say for sure if it's contributing or not. But when we weigh that risk or benefit, since the benefit is so low, any potential risk favors get rid of the medication and see if we're getting a benefit by stopping it. Some other categories to go through: diabetes. We want to make sure that we have looser blood sugar targets as we age, again, because of the increased risk of death that's associated with hypoglycemia. Even a single low blood sugar is much more dangerous than living in the 200s for your blood sugars. So even endocrine agrees with us now, and the AGS says A1C less than 9% is acceptable for the older adult with a frailty syndrome or dementia. Endocrine says less than 8, so I typically say, let's hedge our bets and say, as long as you're somewhere between 8 and 9% of your A1C, you're probably fine for blood sugar control. What that equates to is an A1C of 8 is a fasting blood sugar of 225. So as long as on average your blood sugars are 225 or less, you're probably fine. We have government agencies that are looking over our numbers, and they're not going to be fine with that. But as long as you document the reason why you're loosening blood sugar control and allowing it to be higher than what is standard of care, you typically are okay. And in particular, we especially want to avoid glipizide and the other drugs in the sulfonylurea category in the older adult, because those have a much higher risk of hypoglycemia if patients skip a meal, whereas we don't get that with the DPP-4s or metformin or things like that. In terms of the GI system, one of the big things to worry about is anticholinergic effects. Pretty much all the antidiarrheals are profoundly anticholinergic. So use them if you need to, but use them knowing that it's going to be at a cost. And so typically if a patient needs an antidiarrheal agent, especially if they have dementia, I'm going to counsel them on the risks of delirium associated with taking it and say, hey, here's like a 3-day supply. If your diarrhea is not better by then we need to go back and reevaluate what's going on here and not just rely on the antidiarrheals continuously. And in terms of heartburn management, we also need to worry a little bit about the anticholinergic action. I'm a lot more likely to give PPIs to my dementia patients than I am to give the H2 blockers like ranitidine, because the H in the H2 is histamine. And while it largely binds to the histamine 2 channels, not the histamine 1 channels that the brain has, nothing's perfect, and you do get some cross-reactivity. So, ranitidine has an ACB score or anticholinergic burden score of 1, so it's very small in terms of effect. But again, anytime we can avoid anticholinergic meds, the better for our patients with dementia. And the other thing is, I always say this is the most important medical textbook of our time. I've met many a resident who forget this, that it's normal to poop every day, and it is not normal to go without pooping every day. And yet we have patients that sit in the hospital for 7 days with no bowel movement, and everybody's like, they're in the hospital, it's fine. It isn't. Constipation is the number 2 cause of delirium in the older adult, right underneath UTIs. And making sure that we are aggressively managing constipation can often help significantly lessen behavioral agitation in our dementia patients. Case in point, we had a patient that got admitted to senior behavioral health a few years back who had come in for, this one wasn't even somebody with dementia. A year later she developed dementia, so she was probably on the trend toward it, which probably is what put her at higher risk of this delirium. But she came into the ER for catatonia. Son gave the history of, she has a history of depression with catatonia. And has had it all her life. It started in her 20s. She's had like 5 hospitalizations since then for catatonic episodes, and every time it's the same. She starts withdrawing, she doesn't come out of her room as much, then she won't get out of bed, then she stops eating, and then she just lies there and you can't interact with her. And so sure enough, that started happening to the patient again. So he brought her to the ER, gave that history to the ER, gave it to the psychiatrist. The psychiatrist asked the ER to medically clear her. The ER looked her over and said that she was medically clear. Up she came to SBH. So I get there and I go in to see her, and she's a lot more than just catatonic. She is frankly obtunded in front of me. I'm, sitting there digging my knuckles in, sternal rubbing her as hard as I can, and there's absolutely no response from her. So, in a catatonic patient, you annoy them enough, you should get some response. And so seeing no response is a red flag that maybe this isn't catatonia. There's this thing called a hypoactive delirium that people often miss, because it's not the typical delirium that we see of somebody agitated and throwing things and punching and just being belligerent. Instead, they just kind of lie there and they don't do anything. And so it's much easier to miss hypoactive delirium. So I started talking to the son about medical stuff. And so I get to constipation in the review systems, and he's like, yeah, she does have an issue with constipation. And I was like, okay, well, what do you guys use for it at home? He's like, well, mom's having a little bit more trouble wiping herself, and so I have to help her, and she doesn't like me to do that because it's kind of gross. And so we give her some milk of magnesia like once a week, and then she has a bowel movement. And then we're done for the week, and we move on to the next one. And I'm like, well, that's not enough, but did she have a bowel movement this week? No. Okay, when's the last time you gave her milk and magnesia? I don't remember. So I roll her over, and sure enough, she's massively fecally impacted. She wound up needing serial fecal disimpactions manually for the next 3 days. But during this time, psych made no changes to her psychiatric meds, and by the end of day 3, catatonia was resolved. She was up walking around, and she got discharged from the psych unit with no changes to her psychiatric meds. But here she was. She had been seen by an ER doc and a psychiatrist, both of whom thought this was depression with catatonia and thought that she was medically clear, is they hadn't looked close enough at the simple stuff. This is somebody that could have wound up getting ECT when she didn't need it, because that's what they had wanted us to work her up for. The other thing, when you're that severely constipated, give it another couple days and you're going to develop an Ogilvy syndrome, which is where your gut gets so dilated by stool, it could actually block off blood flow, and then you start getting ischemia of the bowel. I've had patients wind up in the ICU from severe Ogilvy syndrome and even die from it. Making sure that we're managing somebody's constipation is a major, major factor in terms of delirium management and prevention. One warning on that is fiber. Dietary fiber is kind of the go-to first line for constipation, but we want to avoid using fiber supplements in patients with dementia or in patients who are in institutions, in a nursing home or in the hospital, because both those groups of patients have what we call restricted access to water. When you're on a fiber supplement, they tell you to take this with a full glass of water and drink as much water as you can throughout the day, because you really need that water to pull in liquid into the stool so that it doesn't just bulk up into a big old rock in your gut. And if you don't take fiber with enough water, then you do get these rocks of stool in there that just get too hard to kind of pass out normally. And so we could see constipation increase in patients who don't drink enough water. And if you're in a hospital or in a nursing home, you're reliant on somebody else to come bring you water to drink. So if you don't remember to ask or push your call button, or you can't remember to push your call button because you have dementia, you're probably not going to get enough water, and fiber is going to have the inverse effect. So in those patient populations, I usually start with an osmotic laxative, something like Miralax, and then up titrate from there rather than starting with fiber. Pain is another kind of big area to focus on. Is that, there are a lot of ways we can address pain, and there's a lot of ways we can address pain in a way that makes the patient worse in terms of dementia and delirium risk. I've already mentioned the NSAIDs a lot, ibuprofen, Celebrex, all those non-steroidals. We typically want to avoid those in older adults because of the increased risk of stomach ulcer formation, as well as the nephrotoxicity that they carry as we age. The Academy of Nephrology says that they recommend no oral NSAIDs at all above the age of 75 because of these risks. So using topical versions of NSAIDs, things like Voltaren, often work a lot better, especially if we're using them on small to medium-sized joints, hands and knees, things like that. It tends to have good effect, but low systemic absorption, about 6% compared to taking an ibuprofen pill. So that has a lower risk of developing all these kind of systemic side effects. And also opiates, we're really realizing how much we've overdone it on the opiate prescriptions. And typically I try to avoid opiates if at all possible in my patients with dementia because it's a cognitive suppressant and you can induce a delirium with it. And so focusing on non-opiate analgesia for chronic pain is appropriate. If you've got acute pain, you got a broken bone or something, yeah, maybe you do need a short course of opiates, but time-limited course with a reevaluation after time has gone by. And those are the kind of major highlights. So to kind of drive it home, here's a good example from clinic. Now let me make sure we're on time, which we are. So this was a patient that had come in to see me for evaluation of memory problems at our memory disorders clinic. And had a history of hyperlipidemia, asthma, had been in an assisted living facility getting medication management because he'd been having difficulty managing his numerous pills by himself. Had kind of all the typical amnestic symptoms of late onset Alzheimer's disease, had IADL deficiencies, and lost his driver's license due to crashing his car in a parking lot. Actually, it was at the DMV when he was going for his written test. And then he failed the written test too. So probably not good there. So all of which was kind of consistent with he did have a diagnosis of dementia. But the question that the patient and the family had asked me is, what do we do about his medications? Because A, he's having trouble managing it, so we've got the assisted living managing it now. But he was at an assisted living that was charging per pill. And so a lot of places will charge you like X amount if you're on like 6 pills or 12 pills or 18. So kind of lessening the amount of pills can often save cost for families. And so I said, okay, well, what's his meds? And so here's the list that he came in with. And so he was on a lot. But when we actually look at it, a lot of these were things that were not really prescription meds. There were a lot of supplements on here. And then also with the prescription meds that he's on, there's a lot of unusual things too. This is the issue that we frequently face in geriatrics is, we get a med list like this, what do we do about it and how do we address it? The good thing with this one is the family was very willing of, I want to stop anything that's non-essential. So I'm like, great, we're just going to carve everything. And so this is what we wound up doing with him. It takes time to do this, but being able to sit down and take that time to just go line by line and see what's the point of all this can suddenly start to help you realize there's a lot of stuff people wind up on that we don't really know what the point is. He's taking ascorbic acid 500 milligrams a daily, and he was taking that coupled with a multivitamin, coupled with some vitamin C, glucosamine, chondroitin, manganese, coupled with vitamin E, coupled with CoQ10 and cyanocobalamin. And the reason he was on that big regimen is that he had had a wound like 10 years ago that his wound doc had told him to take all these to help with wound healing, and nobody ever thought to stop him. But there's no benefit to taking those just kind of for routine use. We don't see that there's any kind of outcome data in terms of looking at these vitamins. Most of that comes from looking at the multivitamin with minerals daily. And there was a good New England journal back in 2012 that found that for routine multivitamin use in the older adult, there were no outcome data in terms of morbidity, mortality, or quality of life in patients on multivitamin compared to not. And they had dedicated a whole journal to articles about the multivitamin, and nobody could find anything that they did. But they are constipating. One of the minerals in multivitamins is iron, and iron can constipate you. So if you don't need to be on iron, don't take it. So we got rid of pretty much all of his vitamins for that reason. But then he had also been on some other things that it was like, I don't know if you really need this. Since he's got Alzheimer's disease, that increases his risk of cerebral bleeds from these kind of microvascular hemorrhages. And so if you don't have a reason to be on aspirin, you may want to get off that because it can reduce your risk of bleeding. There was this trial called the Esprit trial back in 2018 that showed there was no benefit to primary prevention with an aspirin above the age of 75 in terms of looking at heart attack or stroke risk. And so we got rid of his aspirin based on that. He was taking cetirizine for allergies, so we got rid of that, told him to just stick with his Flonase instead because cetirizine is anticholinergic. He was taking ezetimibe because he had a history of myopathy with statins, so they said, hey, take ezetimibe instead, but he was still having lower extremity weakness, and ezetimibe itself can increase your risk of myopathy similar to a statin. Plus, he was only taking it for primary prevention, and again, at his age and with his dementia, the time to benefit of ezetimibe would be at least 2.5 years, probably more on the order of 5 to 10, so, the benefit just didn't really outweigh the risk. Some others that jumped out is taking ginkgo, as well as vitamin E for his dementia. The literature hasn't found that there's been benefit in terms of cognitive outcomes in patients on vitamin E or on ginkgo, but they're still commonly given by homeopaths and by the lay media for drugs that may help with memory. But the problem with both of vitamin E and ginkgo is they both increase your bleeding risk. And they actually do each one is about the same as taking a baby aspirin a day in terms of the anti-platelet effect that those two vitamins have. So he's kind of taking 3 different baby aspirins a day when he didn't even need one to begin with. So we got rid of those. He was on hydroxyzine for itching. We got rid of that because of the anticholinergic effect. And also the fact that his itching was probably because he was on a hydrocortisone cream for the itching, but hydrocortisone's thinning the skin, and his itching's more likely from having thin skin that was dry. And so instead we got rid of all that and said, here, use a moisturizing cream instead, and that may help reduce your itch. And also got rid of omega-3s. So, you can sit here and start carving off meds, and the question becomes, well, some of these, there's no benefit, but there's no harm, so why stop them? And the answer there is polypharmacy. So polypharmacy is defined as taking 8 or more pills in a given day, depending on one study you look at, or 4 or more pills in a given day on another study. And the reason they define it as that is that, especially at the kind of 8 limit, once we get to 8 pills in our system in a day, we can't predict statistically how those pills are going to interact with each other. Those side effect profiles on pill bottles are there based on taking that pill largely in isolation or in a very controlled subset of other medications. So, if you're on, aspirin, but you're also taking it with all these other drugs, who knows really what the aspirin side effect profile is when in combination with this specific cocktail. But what we know is the more drugs you add, the more unpredictable and the more likely side effects become. So anytime we can lessen non-essential meds, get rid of things that aren't having any clear benefit, it winds up benefiting the patient in terms of that polypharmacy reduction. And if we can reduce polypharmacy, that, at least in the literature, has been shown to be associated with a reduced risk of delirium. And for the sake of time, we'll skip through this one that was a redundant one of showing just another example of de-prescribing. So this is the slide I said I always like to end on, is that, when we're thinking about how we prescribe for older adults, these are kind of the mantras that geriatricians live by. is anytime we're starting a medication, we always want to start that thing with a low dose and titrate it up slowly as tolerated. A good example of that is levothyroxine, a medication for hypothyroidism. Normally, the teaching is when you're starting levothyroxine to start it based on a weight-based calculation. Take the patient's weight, multiply by a certain factor, and then that's the dose of levothyroxine you should start with. In the geriatric patient above the age of 65, it's actually recommended not to do weight-based dosing, but instead to start levothyroxine at no more than 50 micrograms a day, or if you have cardiovascular disease or AFib, to start at no more than 25 micrograms a day. And eventually, you're probably going to need to get to that weight-based dosing, but the reason that they say start low is that as we age with these kind of nodal changes that we have on the heart, we have an increased risk of irregular heartbeats. And if you're suddenly going to take a large dose of levothyroxine that your body's not used to, hyperthyroidism can induce tachycardia. And if you've already got nodal dysfunction, that tachycardia can flip you over into an SVT or into RVR with atrial fibrillation. And we see that there's higher risk of this if you start at a high dose of levothyroxine. So instead, they say to try to minimize that risk, start with a low dose and then slowly titrate up over a period of 6 to 8 weeks toward a target weight-based dose to try to reduce that risk. Avoid starting multiple meds simultaneously if you can. It's often hard to do, but if you can start just one drug, all the better, because that way you can help parcel out, is the side effect the patient develops from this med, that med, who knows if I've started like 5 meds at once. And whenever we're prescribing a med, ask yourself these questions. Is this necessary? What is the goal I'm trying to achieve with it? And does the benefit of this med outweigh the risks associated with this medication? Instead of using a med to address this issue, can I maybe address this by stopping another med instead of starting a new one? What is the way that this drug is going to interact with other drugs in our system? Most importantly, can the patient afford it? And can I treat 2 conditions with one agent instead of using two different pills to treat? And if we can try to ask ourselves these questions about any medication that we start, it's going to help us be much more conscious about medications we prescribe and hopefully reduce the risk of harm to our patients. And so, when I've got an agitated patient in front of me, this is the reason why my answer is always, what's their meds first? And then we'll deal with the agitation after that, is because often through addressing the meds, you can address the agitation to a significant degree. And that is all that I got.